Thanks very much. Our last speaker of the afternoon is Dr. Luke Zahn, a vascular surgeon at the University of Arizona, who will talk to us about the not-so-basic, non-invasive vascular tests.
Thank you, Dr. Conti. Can I have the press? I do have a few disclosures. First, I'm the last thing between you and cocktail. Second is I don't have video. Sorry, Dr. Montero Baker. Nothing can top that performance. And third disclosure is even Dr. Montero Baker and I train in the same program. I don't have membrane and I don't have full thickness beer. So what I'm going to talk to you is about the Vascular Lab. The goal is to measure perfusion. And why is it important? And we're all aware that the degree of perfusion or severity of ischemia really is a key determinant for wound healings. And classically, and the perfusion is measured indirectly. One common method is with ABI and toe pressure. So that really is measuring the pressure as a surrogate for the flow, as the pressure is the driving force for the perfusion. And Dr. Gibbons gave you an excellent talk on the Vascular Lab, how you evaluate based on clinical examination a vascular non-invasive test. Showing here is a typical ABI and toe pressure measurement. And this patient, she has a triphasic waveform, and she has ABI 0.97 on the left, and then toe pressure of 106, and with pulsatile on toe waveform. So this is normal. On the right side, the ABI is reduced to 0.76, so she has a mild degree of peripheral vascular disease. And very often in our disease diabetic patient populations, there's an ankle artery medial calcinosis, so the ankle artery is non-compressible, as shown in these non-invasive studies. But unfortunately, we can still go more distal and measure the toe pressure and then derive the toe brachial index, and then we can also look at the waveforms. So even their ABI is unreliable in this setting, the toe pressure is still indicative of the degree of perfusion, and he does have a severe peripheral vascular disease as reflected with TBI of 0.3 and a flat tail wave. So the Society of Vascular Surgery threatened limb Wi-Fi classification utilize the ABI and toe pressure to grade the degree of ischemia. But there is several limitations. Even the toe digital end artery can be calcified, and that precludes the measurement of toe pressures. And very often there's open wounds, prior amputations, or presence of infections that precludes the measurement of ankle and toe pressures. And then what we have to really realize, what it really measures is the global perfusion of the foot. And in the presentation from Dr. Montero Baker, and what we really want to know is actually the regional perfusion, in particularly at the area with the wounds. That will really help us to determine the degree of wound ischemia as opposed to foot ischemia. And then ABI and toe pressure is ineffective, insensitive to detect any microvascular disease. One alternative vascular lab measurement is the transcutaneous oxygen tension. It uses a probe to measure the TCPO2, and then it reflects the degree of ischemia indirectly. Again, there's a serious limitations of TCPO2 measurement. In fact, the literature, the most evidence support the utility of TCPO2 in determining amputation level, but not much in the ischemia of foot, and the utility is more limited by its limitations. So now, how do we improve on our toolbox? One of the emerging techniques is using indocyanine green ICG angiography. And ICG is a dye that's been proved in 1959 by FDA. It is inert, water-soluble, and non-radioactive. It binds to the plasma proteins, and that confines to vascular systems. And the half-life is about 150 seconds, and it's excreted by liver into bile. It can be excited with laser and emits about in the 750 to 950 nanometer spectrum that can be detected by CCD camera. And the intensity has been shown to proportional to the perfusion. And the safety profile is excellent. It has a very low toxicity. Compared to fluorescein, the adverse event is 1 out of over 300, as opposed to 1 out of 200,000. And side effect is pretty small frequency. And clinically has been utilized to measure the organ perfusions in the evaluation of eye, and then tissue and organ perfusions in the setting of a bowel, skin, muscle transplant, and tumor perfusions and the coronary artery bypass graft intraoperatively. So we first test whether we can utilize the ICG angiograph in the setting of peripheral vascular disease. The standard protocol involves injection of this IV dye. Then we time it and recording the appearance of fluorescence recorded on the CCD camera. So and then plotted as a time over intensity, and we got this saturation curve. There's 3 phases. One is called ingress phase, where the pixel density climb until you reach a plateau, and then the egress is corresponding to the washout of the dye from the vascular bed. So this is a kind of a proof of concept case reported from Salsa group, where we perform the ICG angiography. A patient presents with the 4th toe gangrene and the peripheral vascular disease. At the time of presentation, it wasn't clear how much of how extensive is the tissue damage. And then this is the presenting and ICG. It's kind of like eyes of a storm. If you see a red, that means it's hot. It's good. If you see blue, blue is basically background. That means a lack of perfusion. Despite a prolonged waiting, the standard protocol will wait for 2 minutes. Usually the saturation is reached within with 30 seconds. So after we perform angioplasty, and then we took a patient back and performed the post-revascularization angiography. Now all the tissues, including 5th toe, lights up except for the 4th toe, and that's non-viable. It's dead. And so he subsequently underwent amputation and healed that toe. Based on this kind of pilot studies, we went on to develop a series of patients to validate this angiographic technique in peripheral vascular patients. So what should we measuring? We look at the different parameters. One is how fast is the density of signal reaches a plateau. We call it ingress rate. Second is the absolute value from baseline to the plateau. And then we also look at the egress rate, how fast you washed out, and then how much it gets washed out from a plateau. And we correlate to the traditional ABI and toe pressure. And what we found that through our series that the ingress rate of 27.3 correlates to ABI 0.4. And then also the ingress rate of 1.1 pixel on density per second corresponding to ABI 0.4. What it means is we can demonstrate a correlation between the dynamics of the ICG angiographic signal, and the most consistent correlation is actually among patients with severe limb ischemia, where this arbitrary number corresponding with 0.4 consistently. What the benefit it offers us is it's independent of the pressure measurement. So in the cases of where ABI toe pressure is non-reliable, we can still perform this as an alternative evaluation for perfusions. So I'd like to present a case to demonstrate the utility of this as our tool. This is an 83-year-old female. She has a 4th to 5th toe gangrene and a right forefoot wound, non-healing. Her ABI is 0.3 with a flat toe waveform. So based on Wi-Fi classification, she's a wound 2, ischemia 3, and infection 0. That put her into the clinical stage 4. That's a high risk for amputation. And anatomically, she has a task D with a long segment distal SFA and popliteal occlusion. So we performed a superficial femoral to anterior tibial bypass with a vein graft. And showing here is a ICG angiography study before and after bypass. As you can see, the ingress, the absolute value is 56. That significantly increased to 76. But more drastically is how fast it gets there, from ingress rate of 1.1 pixel intensity per second to increase to 5.6 pixel density per second. And clinical outcome is satisfactory. She was able to heal the wound. So this is the value tool, and it's a real-time qualitative measurement. We can see it's happening in front of the eyes. And with a careful selection of the value, how we set the threshold, we're able to detect the regional flow, especially around the wound areas. And it's not affected by calcification, and it's safe. And our preliminary data support that this can correlate with clinical outcomes of revascularization. It does have its limitations. It's not perfect. It's limited to the depth of 5 millimeters, and it requires IV injections. And in a small population patient, they do have adverse reaction due to iodine and sulfur allergy. So always there's more gadget coming, and there's more tools being developed. One of the investigational tools utilize the Hypo spectral imaging of oxygenated and deoxygenated hemoglobin. This is a commercially available systems. Essentially, I mean, without going into the depth of the physics, we can just imagine this is a gigantic array of oximetry, and that converts the signal into arbitrary colored in a spectrum that's depicted the level of oxygen, the percentage of oxygenated hemoglobin versus a deoxygenated hemoglobin. So one of the preliminary study from a collaboration between UCLA, Philadelphia group, and Cleveland Clinic, they tried to correlate this with the group of patients who presented with ulcer. And some of them healed after 24 weeks, and some of them failed. And they want to see characteristically what it looks like with this imaging modality. This is an example. On the top is the initial presentation of the ulcer that eventually healed after 24 weeks. And this is the one that failed to heal. And then you basically, visually, you can appreciate that in the area they measured around the ulcer, there's a more red or purple, which is better. more oxygen in the hemoglobin as a surrogate for the perfusion, as opposed to the ulcer that doesn't heal, there's more green, it's a cooler color. So based on their series, and when they do a histogram plot, and they group look at the distribution of ulcer that does not heal, represented by this filled diamond, versus ulcer that healed, represented by these filled gray circles. And they can derive a threshold, which is an arbitrary value, but at this threshold, the numbers derived from the imaging analysis. To the right of this threshold line, majority of ulcer, 90% of ulcer will heal, corresponding to 90% of the ulcer that healed. And the opposite is to the left of the line. So what I want you to get out of this short presentation is it is difficult, it's challenging to measure perfusion. Even we have established tool of ABI and toe pressure, but the patient is changing, and there's been new challenges, and there's always a new tools, and we have to be open-minded and willing to adapt and think out of the box to implement what we call a disruptive technique to tackle the problem we are facing. This is by no means the future. This is the future, and that's what we experience. And it is a movable feast. Thank you very much.